Hello everyone, I hope you can hear me. So today is another webinar with Mira. So I'm Sylvia, I'm the CEO and the co-founder for Mira. And today I'm so happy because we have a Shelley from the Famlee, and she's the co-founder and CEO for Famlee. And also we have Dr. Fariha, and she's the OBGYN doctor. So today we're gonna talk about unexplained infertility. I know that's a topic many of you guys have been really interesting. And as usual, I like to say hi to you. I cannot see your face, so please put in the chat box. It should be on the right hand side if you log in from your computer or somewhere from your phone. So yeah, please say like where you come from. I like to know about this. So hi Jamie, it's coming from California, and hi John. Okay, someone from Denver, some from New Jersey. That's great. So then I will let the maybe Dr. Fariha and Shelley to introduce yourself.
Do you want to go ahead first, Shelley, or do you want me to introduce myself?
Go ahead, since you're on the slides next. So.
Okay. All right.
Oh.
I'm
going just go back,
further
please.
on the thing.
Go to the other direction. There you go.
Okay. All right, so I'm Dr. Fariha DiPasquale, and I'm a functionally trained OBGYN, and I am the medical advisor for Famlee Fertility. And before we start, I want to kind of tell you a little bit about myself and how I got to this place. So I've been in practice for approximately 20 years, doing general obstetrics and OB-GYN. I did my medical school at Northwestern University. I did my training at Cornell Medical Center. I practiced in New York for a couple of years, and then I moved back to Chicagoland area, where I joined a very busy, thriving private practice with Chicago Women's Health Group. And so we did bread and butter OB-GYN, the whole gamut of OB-GYN. I felt like I was well trained. I thought I gave excellent, care, and I thought I knew pretty much most everything I needed to know about like women's health. Fast forward a couple of years, my oldest son was born. So my, I had a beautiful pregnancy. I don't really have any major family issues, and he was born perfectly healthy. And then when he was between like 2.5 and 3.5, probably like what would be a parent's worst nightmare came through as my son like regressed into autism. My husband and I are both like traditionally trained doctors, and we really were very, very frustrated on how our beautiful boy's brain and body all of a sudden was starting to fail him. So we looked at sort of everything that we could to like help him in terms of all aspects of medicine. And we were quite frustrated not really getting anywhere. Basically, somewhere like about a year after his diagnosis, he actually also started to develop like seasonal allergies and asthma. So we actually put him on a medication called Singulair, which is really meant for like asthma and allergies. All of a sudden, my son's speech improved. All of a sudden, his eye contact improved and stuff. And it really was kind of like this aha moment for both me and my husband to really would be like, well, how come this asthma medication is really changing his autism symptoms? And I think that was kind of my basic introduction into functional medicine, where we're really looking at root cause and interconnected body parts and how they all play into each other to basically sort of optimize health. And I really felt like really kind of sad to say that I felt like I was like a well-trained physician, and I realized I really didn't know a lot about like immune health. I really didn't know a lot about like hormonal health or inflammation or how to optimize those. So after I started to see success in my son's health, I really started to apply those things in women's health. So PMS, migraines, and fertility. And, as I became comfortable, I really started to see a lot of progress can be made by looking at the body this way. And then eventually, because of this, I pursued a functional medicine training certification. And now, while I still practice, traditional OBGYN medicine, I really view things from a functional lens. And I think the reason I'm going through such great explanation to sort of, highlight my story is the fact that I think it kind of goes to the fact that some really well-trained physicians just may not be looking at the body at this angle. And this is what I want to do today is basically I want to help you introduce you to sort of the functional medicine view of infertility or fertility for that matter. It is a lot of material to cover in 20, 25 minutes, and please feel free to take notes and we'll answer any questions that you may have at the end. And then we have our contact information too, and feel free to reach out to us afterward if you have any questions there. All right, so if I can get the slide deck to work. Okay, so what is functional medicine?
Hold on 1 second. I'm sorry, Dr. Fariha. I also want to give a chance for Shelley to introduce herself as well. And then,
sure.
Yeah, we just had some, small housekeeping stuff to talk about, and then we'll go to your slides.
Sure.
Thank you.
Sounds great. Thank you, Dr. DiPasquale, for sharing with everyone what you'll be covering today. So my name is Shelley Bailey, and I'm the founder and CEO of Famlee Fertility. I came from a 20-year background in specialty pharmacy, and Famlee was really founded out of my own fertility journey. By the time I wanted to expand my family, I was already considered geriatric, and I was just having trouble getting pregnant, and my OBGYN said that she would send me to IVF. I was interested in pursuing IVF, but thought that there might be a little more we could do before we got to that step, and that is how Famlee was born. At the end of Dr. DiPasquale's presentation, I'll go ahead and share a little bit more about myself, but I just wanted to say hello to everyone here and thank you for participating in this webinar today. I also thought I'd mention for those who stick around till the end of the presentation, we will also be giving a coupon code for an additional discount off the Famlee Fertility Program.
Great, thank you so much, Shelley. So I think most of the people here probably know me. I'm Sylvia. I'm the co-founder and CEO for Mira. So Mira is the fertility tracker. We measure your hormone. We measure multiple hormones numerically. This is the only product on the market you can measure in that kind of accuracy. And also your data will be synchronized to the Mira app. So it's automatically tracking and see the trending of your hormone level. So regardless what goal you have, maybe you're trying to have a baby or trying to improve your hormone imbalance situation, or just to know more about your body, and then you might find the some help Mira could provide to you. And I'm also a very delayed mom. I had my first baby after 35 years old. I'm always been surrounded by a whole bunch of women, and they have to go through IVF, unfortunately, where many of them being diagnosed with unexplained infertility, which is very difficult to understand and people don't know what to do. So this is my starting point. I want to help us and help fellow women just like ourselves, and with more scientific tool, more accurate results, and also personalized actionable guide we can give to you, so we can have a better control of our own health. So before we start, just some really quick disclaimer. So anything in this presentation is just for educational and informational purpose only. So it's not gonna replace your medical advice. And also, if you have questions, please put into the chat, and we have moderator from Mira, and they will, they will flag those questions. And at the end of these sessions, there's gonna be a Q&A part, and we're gonna address all the questions together. And one last thing before we start the presentation is, as usual, you guys know that we'll have some poll. We'll have a few questions for you. This is just to help us to know more about the your situation, like what you're interested in, so our content can be more better towards you. So please help us to fill 3 polls on the screen. I'm pulling them for you right now. So okay, so you should see 3 polls on the screen, and we'll give 30 seconds to do that. So we have 88% of audience today. They're actively trying to get pregnant. And we also have about 70% of audience today. They are they've been diagnosed with unexplained infertility. Okay, and about 60% people are tracking their fertility hormone with Mira, and about 14-15% is using at-home test kit. I'm really glad to see you guys are tracking the hormone and paying attention to your own health. That's very important. That's really good awareness. Okay, 10 more seconds for the survey. And we're gonna go to the next. Okay, great. So without further ado, I'm gonna give the stage to Dr. Fariha. So Dr. Fariha, you can navigate the slide back and forth by yourself. And here's your presentation.
Okay, so let's start with like sort of what is functional medicine. So functional medicine looks at the body from a whole health view. It doesn't look at seeing as specifically diseases, but as systems that are maybe off balance or have gone awry. And the emphasis here is, again, on like a whole body system, and we will discuss things in the matter of energy and metabolism and stuff, and not specifically, oh, your ovaries do this or your uterus does this. And when we look at things in this way, we're really concentrating a lot more on function of the organ rather than really the structure of the organ. And when we look at this way, we're also looking a lot more at the root cause or underlying issues. And I think that this actually aspect can be really well applied to fertility, where often it's not so much that somebody is infertile, but there may be just a whole bunch of systems that are off balance. And then if we can sort of fine tune them, we often end up actually having really good results. So what is the traditional versus a functional medicine approach of fertility? So functional medicine approach is comprehensive. It realizes that the body is all interconnected and doesn't treat reproduction as an individual process. It is at the same time individualized. It recognizes the individualized aspect of a woman. So it looks at lab and data and looks at to see, what's making you unique. We're not all statistics, right? So our labs vary from our own baseline. And it basically takes that look to see how does this fit into the rest of your fertility journey. And the nice aspect is that this actually can be really applied to any stage of fertility that you're at. So maybe you're just starting to try or preconceptional and you want your best chances to have a healthy baby. Maybe you've been trying on your own without success. Maybe you have a certain diagnosis like PCOS or endometriosis, or maybe if you're deep into the IVF journey. All of these places can somehow optimizing things in a functional health manner will optimize that stage of your journey. And so when we look at fertility in that setting, we really have a pretty expansive vision. So traditional fertility looks at is a woman ovulating? Are the tubes open? Are the sperm adequate enough? Well, functional medicine will also look at the quality of the egg and the quality of the sperm, metabolic factors, thyroid, insulin, what are the stress how much stress is she under? What are her toxic exposure? So when we look at fertility in this setting, or let's take a look at fertility in this setting. And what I think to do that, the best thing is to really understand what is the requirement of fertility. So first and foremost, the body needs to be satisfied or have reserve. So this is also like a very important functional medicine concept. And what that does is it basically puts hormones in like a pyramid with sort of a hierarchy of need. At the very base of the hormone are your adrenals. That's your cortisol, norepinephrine, epinephrine, and stuff like that. These are the hormones that your body thinks are crucial to survival, and it will do whatever it needs to protect that survival. And so if there's something that is threatening that survival, it is going to really push energy and resources to that base. So, the threat to survival sounds like very ominous, but threat to survival does not need to be a a really bad disease. Threat to survival is a woman who's malnourished. Threat to survival is somebody who's acutely calorie restricting. Threat to survival is anyone who's over exercising. And threat to survival is also anxiety. So, there may not be a real danger there, but there's a signal to your brain saying danger, danger. And what is your body doing? Saying, hey, really force up that, really fortify that base and shunting your energy there. So if the base of the hormone is really for survival, the middle two hormones, thyroid, insulin, and I tend to put actually vitamin D here as well. These are your hormones that are really kind of balancing everything. And their goal is really thriving, not just surviving. They're micromanagers. They take other body processes and other hormones and sort of say, hey, go here, go there, go there. And it's very important that we actually balance these, because these will send a thriving signal. And once you have a thriving signal, then the body has enough energy to go higher up on the pyramid, which would be the sex hormones. So your sex hormones live on top. They're the icing on the cake. They really are the extras. They only really get attention when the bottom two tiers are satisfied. So this may be a little bit of a different, approach to look at, but it kind of makes sense, right? It makes sense. Like your body is smart, is constantly sort of regulating itself, and is constantly sending other signals. And those signals can be like, hey, hold on a minute, we got some issues going on here. Stop taking on extra load. And pregnancy would be an extra load. Or the signal could be, hey, everything is great. Let's go ahead. Let's make more of us. So it sounds hokey, but I think it's actually a beautiful concept that really appreciates the intricacy of your body and its way to sort of preserve itself and send this. So the whole goal is survival, thriving. We want to reach thriving so that we could actually have room for the top. And I'm going to come back to this concept over and over in my slides. And so let's say we got the pyramid cover. So the body has reserve. Now we have to nurture the egg. We got to make sure it's ovulated in a good manner. We want to make sure that the sperm is of good quality and quantity. Cervical fluid is optimal. Tubal transport is good. The lining is hospitable for implantation. And then the uterine environment continues to support that embryo. And so quality of the egg. How do we make good quality egg? Well, the traditional focus is always on the age of the woman. So yes, a woman starts off with about 1 to 2 million eggs. By puberty, you're down to like 2 to 300,000, and you're going to ovulate somewhere about 3 to 400 over the course of your lifetime. And that, unfortunately, as a woman ages, there's more DNA damage. And that, unfortunately, is a factor that is a big obstacle for a lot of couples and cannot completely be modified. But if you're going to release that one egg, are there modified factors that we can do that say, hey, let's make that egg a better quality than the other one? And I think more and more data says that is the case. And so factors, those are going to be nutrition. So egg recruitment for a particular cycle begins 6 to 9 months before you truly actually ovulate. And so this is your window of opportunity. This is where you're going to nutritionally nurture that egg to be the best it can be. And how can you do that? So what is important for nutrition? Well, reproduction is an energy-rich project for your body. So it needs good, healthy fat. So you're thinking avocados, olive oil, your coconut oil, nuts. Reproduction is also something that involves a lot of DNA repair and damage. So you need antioxidants to clean up all of that. And so thinking berries, green leafy vegetables, fish oils and stuff. And then more importantly than what you need is also what do you not need and stuff. So you don't, you want to not have anything that is inflaming the system. So very cooked char products release these substances that are actually that are inflammatory to the ovary. So you want to avoid those. Chemicals with names that you can't really pronounce and stuff are generally inflammatory overall. pesticides mess with your gut biome, inflammatory. And then for some specific women, gluten and dairy creates a specific inflammatory problem, and we want to avoid that. Large ocean fish is concerned for mercury. Mercury stays in your system for 6 months, so that also needs to be slowly removed. And then finally, in terms of so some of this actually sounds like very kind of like, oh wow, you really need to do a lot, but really what you're really looking at is that you want to get lastly, one other thing would be you want your hormones to be in charge. So you're going to avoid like meats and dairy that have been fed exogenous hormone. So while all of this may sound like really complicated, and like we're not living in a bubble and you're not striving for perfection, all you're really doing is seeing where you're at and see if you can kind of move yourself to a spectrum of better health in preparation to nurture that egg. And often a lot of times doing like a clean, like Mediterranean diet actually satisfy a lot of these needs already. Hormonal health we'll talk about a lot more in detail. And again, here we're looking at thyroid, insulin, and vitamin D. Blood flow is important just because you can have all the nutrients you want. If they're not getting to the ovaries, they're not really supplying things. So hydration here makes a difference. This is why a lot of acupuncture, acupressure, massage helps. They're basically just really increasing the blood flow. Exposure to toxins is an issue. So the biggest toxins here are really what were found in like beauty products. So, overall, like over the course of time, in to favor convenience and for beauty, like we've actually given up a lot of good tenets of good health. And so endocrine disruptors are rampant in our environment. So I usually tell people start cleaning up their environment and their beauty regimen. So BPA, phthalates, and parabens are probably the 3 ones to concentrate on. So, BPA is found in plastic. It's also found in like liners of cans. It's also found on receipts. So that oily surface on the receipt, when you type, that is BPA. Phthalates are basically in anything that's perfumed and not in its natural scent is probably likely going to have a phthalate in there unless they're using essential oils. And then parabens are preservatives that are found in shampoo, body wash, and stuff, very rampant. Again, start looking at them. There is a really good site by environmental working group called Skin Deep, and what that does is you can put your shampoo or conditioner in there, and it'll really tell you its reproductive health consequences. Immune health, again, we're going to go into substantially with some other slides. But yeah, if you're inflamed in other way, you have an autoimmune issue going on, best to address it because your egg quality will be affected. And then alcohol specifically. So we usually very much concentrate on, okay, after you get pregnant, you enter the developmental portion, there's fetal alcohol syndrome, you're going to avoid alcohol. But again, going back to that window of 6 to 9 months of nurturing the egg, there's actually data that shows that if you ended up actually having even moderate amount of alcohol, where you get to the portion that you actually have a significant alcohol level, is cytotoxic to that egg. And so it is better for a woman to have like 3 to 5 drinks on a daily, spread over the course of a whole week, than for her to go out 1 or 2 nights with her girlfriends and have 3 to 5 drinks. So it is really, we're looking for low level at a constant level rather than binge drinking at any one time. All right, so if we look at the quality of the egg, I want to talk about several factors a little bit more closely. So vitamin D. Vitamin D is a fat-soluble vitamin, but really basically in the body acts as a steroid. We get about 80% of it from the sun, 20% comes through a food source. It's taken into our body, first modified by the liver, then modified by the kidney to be its active form. And in that active form, it really is a steroid hormone. It has receptors found throughout the body, and they're really actually very heavily concentrated in they're very heavily concentrated in the reproductive organ. So the ovary has it, the endometrium has it, the placenta has it, and it does several things. It basically nurtures those granulosa cells that are developing that follicle. And again, that's 6 to 9 months leading up to it. There's a lot of development going on. That's why we find that women who have good vitamin D level tend to have higher AMH level, because it's a reflection of granulosa cell function. There's also it also sensitizes that follicle to FSH, so therefore it promotes ovulation or helps with ovulation in that way. It actually works at the level of the endometrium through an immune mechanism to really increase implantation, and it leads to increased progesterone. So while it's traditionally vitamin D we think of as for bone health, it really actually is a reproductive health vitamin, and you want to have about and it's deficient in a lot of people. So the general statistics are that about 42% of the US population is deficient in vitamin D. And in Chicagoland, where I practice, in winterland, I would say it's much higher than that. And generally we consider the optimal level to be like 30. The top level to be 30, but really for fertility and to send that thriving signal, you want to reach like at 50 to 80 range. All right. Other things that are important for fertility: B complex. So, B vitamins they are really needed for energy and metabolism. So anything that's rapidly dividing need a lot of good usable B complex. And so it is important in egg development. It is important in ovulation. It's important in the growth of the baby's brain and the nervous system. Vitamin D, we already talked about. Iron is really, again, oxygenation is a thriving signal. So if you're anemic, you are going to have a little bit delayed statistics. So none of these are like absolutes. It's not like you can't get pregnant, but your body is, again, not feeling optimal. And I sometimes will actually check ferritin, which is a better signal for underlying level of iron reserve, and sometimes actually that cross signals in the body much more than the actual hemoglobin level does. Omega-3s are really nice anti-inflammatories. They thin your cervical mucus, they thin the blood, so there's increased blood flow to the ovary. CoQ10 is an enzyme that is necessary for your mitochondria. Mitochondria are your body's cells, like little organelles. That's the energy source. Good CoQ10 leads to more energy. And again, reproduction is an energy-rich project. And then zinc is really important for immune health. So any rapidly dividing cells, immune health is very important. Implantation, it really involves immune health. And we really find that to be deficient actually in endurance athletes. We find that to be deficient in people who are stressed. We find it to be deficient in people who have baseline GI issues and stuff. So something to be paid attention to. And again, obviously, this is just not a comprehensive list. You need other things too, but these are often the ones I feel like that I need to supplement additionally in people. So the other thing we want to concentrate on the thyroid. So thyroid is the master gland, and it's a gland in the neck, but it really is sort of a master gland, and it's like micromanaging a lot of other processes in your body. And it is associated with, it has direct effect. Thyroid hormone itself has a direct effect on the brain, and then from there to the ovary and on the ovary itself. So it is important in nurturing a good egg. It's important in ovulation. And we estimate that about 1/3 of unexplained infertility can really be actually helped with good management of thyroid. And there's 3 important concepts here. One is that there is a normal range or an optimal range for pregnancy. So you may have had a thyroid checked by a primary care doctor, and you may have been told things are normal. And when you're not trying for pregnant, you can have a TSH up to like 4.5 or 5, depending on the lab, and you are normal. But during pregnancy, again, thriving signal, we want it under 3 for sure, ideally closer to 2. And the subcomponents matter. And basic physiology of thyroid is that TSH is by the pituitary, goes to your gland, to your thyroid gland, that produces a T4. T4 circulates it bound and unbound in your blood, and then in your cell, you need T3 to be the effective hormone. So for some people, there's vitamin disturbances, stress, other factors that really actually allow you to have a normal circulation over here, but at the cellular level, your body is not does not have enough T3 and cannot process properly. So that's important. And then TPO antibodies are important. So TPO antibodies are autoimmunity factor. They're not only immune against your thyroid, but they're really a good indicator of whether you're truly in an autoimmune state overall. And when you're in that state, your body is not as optimal. If I can get somebody who has TPO antibodies that are elevated, I really will tell them, do you have time in terms of your reproductive age to really take this a little slowly? Because if you do, you are actually going to decrease your recurrent pregnancy loss. You're going to decrease some other pregnancy complication things too. So it is, if we can pay attention to this going into it, you're going to be all better for it. Second big factor is insulin resistance. So yeah, insulin again is a hormone. People don't think of it as a reproductive hormone, but it has huge consequences for reproductive health. So I look at people like on a spectrum of like diabetes and insulin resistance. I usually will check a hemoglobin A1C, I'll check fasting insulin, and I will check a fasting a glucose. If your hemoglobin A1C or fasting glucose is elevated, well, then you have diabetes, or have a pre-diabetic. In that case, basically, sugar is cytotoxic. It kills cells, it weakens your immune system, it weakens your vasculature, it makes cell division inefficient, and all of these processes are extremely important in a placenta and in a baby that needs to grow. And so in that case, you got to get the sugar under control to really optimize your chances of pregnancy. But often people may not be diabetic, but they may have insulin resistance. And that is really shown by like a fasting insulin level. A fasting insulin level is basically, so the physiology of insulin is that insulin is meant to it's supposed to signal your cell to, hey, take the glucose in. If you constantly chronically have too much sugar, where your cell is like, hey, too much sugar coming in, shut this off, it will develop resistance to it. Yet at the same time, your pancreas keeps making more and more insulin. And now it starts to go down pathways that it wasn't supposed to really go down there. And that's where we start to see what is shown in the slide. You're going to get elevated LH. You are starting to get abnormal follicular genesis or formation of the thing. And it decreases something called serum hormone binding globulin. And so not only now do you have more testosterone, but you got less bound to testosterone. So all the effects that kind of happen from that are creating in. And in the special situation where we really see this is sort of like PCOS. So PCOS is an important enough slide that I think important enough concept that it deserved its own slide. So depending on the study you look, 4 to 20% of the U.S. population, average study says about 20% of population it has this. And you got your traditional PCOS picture, which is the woman has acne, she has difficulty losing weight, her LH and FSH ratio are off, her menses are irregular, she's got a little circle cyst around her ovary. You got the full diagnosis. But you got to remember, it's a spectrum. And in the spectrum, you're going to see some people who don't have all those manifestations. And that's especially the case in women who are thin, or women who are basically just coming off of birth control pills. Sometimes you only see a little portion of their picture. And what happens in those settings is they also lie on the spectrum where they are in terms of their fertility journey. So there are women who have PCOS metabolic issues, but they're ovulating regularly. There's women who ovulate, but not as frequently. So instead of having 14 ovulations per year, you have 8 per year. And then there's people who never ovulate unless you help them. And so the root cause here is really insulin resistance. The root cause here is adrenal dysfunction. The root cause here is inflammation, where there's more and more study that shows that gut bacteria and gut health is involved in PCOS as well. And so you really want to address all of them. And I think actually the slide that goes back probably looks at it better, is that if we can get the insulin under control, we can often get the adrenal under control. And then if we can get the adrenals under control, then the end product, which is a high androgens, really don't oppose. They will allow ovulation to occur. They will allow implantation to occur. So some portion of that controlling the insulin resistance is really thing. That's why we give people metformin. That's why we give people myoinositol. That's why we put people on berberine, chromium, zinc. There's several different places that actually decrease your insulin resistance. And those, when you add them either with or without medication, can sometimes get people to either spontaneously ovulate or increase their chances of ovulation with medication. And then the other sort of pesky thing in this situation is the fact that, hey, these women can't sometimes tell when they're ovulating because their LH is always elevated and stuff. So that spike is not only the spike either may not happen and you may not ovulate, or maybe the spike happens, but they can't really do timed intercourse and stuff. So it just sometimes delays their fertility stats because they're really not utilizing even when they are ovulating. All right, so after this, ovulation. So you got good quality egg, you got good, and now you got to ovulate and release that. So here again, LH surge has to happen. We talked about that, how that can be diminished in PCOS. We talked about how it can be diminished in thyroid abnormalities. Prolactin is another hormone that actually can show an effect here. So prolactin is a hormone that is basically secreted by the pituitary, and it has an effect on your ovaries. And what it does is it basically inhibits FSH, therefore egg development and estrogen doesn't happen. And it also inhibits LH surge, and so ovulation doesn't happen. Now, prolactin is normally elevated in certain things, right? So if you're breastfeeding, your prolactin is elevated. That is body giving feedback saying, hey, I'm busy right now. Do not get me pregnant. And so but prolactin can also be elevated by little tumors that sometimes don't have other symptoms. It can be elevated by hypothyroidism. It's elevated in people who have anorexia. Subset of PCOS can have it elevated. And it often is elevated by medications which women take for depression and mood disorder and stuff. Something to keep in mind. And then now when you've ovulated, the one other thing that I think also does not get enough sort of time is, you cannot have a toxic peritoneal fluid. So if you are inflamed, such as a case with endometriosis, they really, when they look at that peritoneal fluid, they find out that is really, it has a lot of cytokines that really kill. It's meant to react and kill against the blood that it's seeing, but it also will be cytotoxic to the egg. So again, inflammation, bringing it down makes a big difference here. So now going on to sperm. And so after we've nurtured a good quality egg, we want it to really we want it to meet a good sperm. And so sperm gets away with a lot, unfortunately, because there's so much redundancy in nature. However, and there are millions of sperm, and all you have to do is really get one good one. And so sometimes the focus just keeps being on women. But if you really look at infertility, 1/3 of infertility, 1/3 to 40% of infertility is due to male factor. And if we can actually get that to be better, we are going to increase our fertility statistics. So nutritional deficiencies are involved here too. So zinc, selenium, CoQ10, vitamin D are important for sperm health. And if your partner is not taking them, something to consider. Heat degrades the sperm. So, that's why you got to avoid, you got to wear looser clothing, and you got to avoid like saunas and hot baths and things like that. And then toxins. So here, I think alcohol affects sperm health. So there's a recent Danish study that looked at sperm, and it went to like people who actually had a drink up to 3 months prior to sperm health. So just like there's a window of opportunity of 6 to 9 months for a woman, sperm starts to develop 3 months prior to it actually is released. And during that time, the study showed that if people had what they called 5 units of alcohol, which is really 1 pint of beer, it's not a lot, that it affected their semen parameter for up to 3 months. And what it did is it looked at basically it alters the volume of the sperm, it alters the way that the sperm moves, and it also shows that the sperm starts to degrade earlier than it would. The other thing is cannabis. So, I mean, cannabis use is so on the rise, and cannabis, unfortunately, is not friendly to sperm. It alters the shape of the sperm, it alters its ability to move effectively, and it alters how long the sperm can live. It alters the LH hormone, actually decreases the LH, which leads to low testosterone in women, in men. So you got low testosterone, which is not making as much sperm. In addition, low testosterone sometimes can have erectile dysfunction as well. And so, I mean, if really fertility is really on like the, rise, this is something you have to, as a couple really kind of be cognizant of. And this is really marijuana that's used in casual ways. So we're not talking about heavy marijuana use here. And finally, there's emerging data on electromagnetic radiation. So there's studies that show if you take sperm in a petri dish and you put it next to a computer for a couple hours, really a large portion of it is degraded. And so now you have to think about that. Okay, think about all the men who carry their cell phone in their anterior pocket, or think about all the people who work with laptop on their desk all the time. So, I think education, again, just to kind of take a look to see, where we're at and what we can modify in our environment. And so finally, you got good quality sperm, you got good quality egg, now they have to meet. So cervical mucus. So cervical mucus, good cervical mucus, it nourishes the sperm. It actually weeds out the bad sperm and actually almost repairs some of the thing. It keeps the cervical canal open, and then it actually keeps the vaginal pH optimal for the sperm to sort of stay in there for a couple of days if needed. And so hydration is a big key here. So you want to make sure you're very, very well hydrated when you're trying for pregnancy, and you want to avoid things that will thicken that cervical mucus. So allergy meds are the common offender and stuff. So allergy meds like Zyrtec, Allegra, Benadryl, they have a systemic effect. You thicken your cervical mucus. So around the time of ovulation and stuff, when you are doing that, and you can see a rise in estrogen that'll lead to that ovulation mucus being formed, you don't want to take those allergy meds. And you may actually even want to take something that actually thins the which thins the cervical mucus, which would be like a commonly prescribed Mucinex is that. I use much more like N-acetylcysteine stuff. And then finally, you want it to be an environment where there's not an infection. So if there's chronic bacterial vaginosis or yeast and stuff, then the cervical mucus function is not optimal. Finally, now the sperm needs to go through the tube, fertilize, come back. And so there's mechanical obstruction. Obviously somebody's had previous surgery or has endometriosis, may have both of their tubes blocked. And an HSG can easily confirm that. And if that's the case, no amount of functional medicine is going to help you, right? You need to probably go to IVF or get special care in that setting. But I have to say, we do a whole bunch of HSG, and without risk factor, it's unusual to have your tubes be fully blocked. More likely, though, there may be some functional damage. And by that, we mean that sometimes the little cilia are basically damaged. And so there's unfortunately no good way to kind of tell that, but you suspect it in people who've had previous STD infections, or people who've have an ectopic pregnancy. And then the last thing is just mucus. So sometimes secretions are thicker. They just plug things up. Things would normally move through, but they don't because things are plugged up. This is why we actually have, increased fertility after people have an HSG, which tends to sort of flush the tubes a little bit. And this is, again, hydration is important here. And a lot of people who go see a chiropractor or a naturopath, they really help improve that blood flow and the lymphatic flow and the fluid flow through those areas. And part of the way that they work is that basically they improve your tubal, I think. Now you're at the endometrium, you got to have a nice thick endometrium to implant things. So you could have scarring from a previous, surgery. You could have organic pathology like fibroids or polyps, and, an ultrasound should be able to evaluate that. It should be able to take care of that. And obviously those need to be addressed if fertility is becoming an issue for you. And there's an abnormality there. But more so what we see, probably the biggest thing that we see is the lining is fine, but there is a progesterone deficiency. So progesterone deficiency or luteal phase deficiency is extremely common. And what is the main cause of it? It basically the main cause is stress and dietary changes. And so going back to that pyramid I showed you, on the very base, you have the cholesterol and you have the adrenal glands and stuff. Very base, you have cortisol. And so cortisol and progesterone, they both come from the same molecule, cholesterol. If you are feeling stressed in any ways, if you are, again, perceived or true stress, your body is saying, hey, make that cortisol. It will take away from making progesterone, and you will have a lining that's thin, and you may have a luteal phase defect. And then the other thing is really lack of fat in the diet. So progesterone comes from cholesterol. No fat, no cholesterol, low progesterone, lining not as plush, issues with implantation. And then finally, factors that go into maintaining the pregnancy. So some of these are, hormones. We've already talked about. Vitamin D still is actually very important here. Insulin, again, thyroid. Genetics are important here because some people have a very common deficiency is an MTHFR deficiency, where you may have your B vitamins, but you can't utilize them. Immune system, again, if you're in a cytotoxic world, you are not going to allow something to implant and grow. And stuff. And so some of these, the nice thing is that if you've really done a good preconceptional care, by the time you get to maintaining the pregnancy, a lot of these issues have sort of been addressed already. So going back to this is sort of the general comprehensive view, functional medicine view of fertility. And this is what we've incorporated into our family fertility protocol. And I hope that you see, the comprehensive aspect of it. I hope you see the individual aspect of it. And I hope you see that it's really all about just balancing and getting your body to sort of be the most efficient that is. And with that, I am going to end, and I am going to pass it on to Shelley and Sylvia to continue the talk.
Thank you so much, Dr. Fariha. I think it was really nice talk, and it's amazing to see how our body works as a whole thing and how everything is connected. So many of you guys might be familiar with Mira. So Mira is the tracker, and that tracks all your major fertility hormones, and we provide you the numeric hormone data, so you see that accuracy very similar to the blood drawing, but without the hassle to go to the lab. And also many of our users have discussed their unique hormone pattern, and sometimes when we're diagnosed with unexplained infertility, we don't know what's going on, but by seeing the hormone pattern, really gonna show something, and it can save a lot of efforts for future downstream IVF if we can avoid that, and also will be really good way to learn your own body. So with Mira, we currently test E3G, LH, and PDG, so that can predict your ovulation and also confirm your ovulation. And the Mira is also PCOS friendly because we detect your hormone numerically. So even your hormone baseline is pretty high or low or whatsoever, you can still see your pattern. So this is very different from the traditional OPK. And also we can detect up to 6 days of fertile window for you. So with a lab grade accuracy. So here's the hormone chart with the which Mira is testing. So the blue line, the thick blue line is the LH hormone. So the LH hormone usually surge right before your ovulation, so you can use that one to indicate the ovulation is about to happen. So that's the that's your most fertile 2 days in the cycle. And also with estrogen, that will rise few days before the ovulation, so that will give you your fertile window. And with progesterone or PDG, that will rise after ovulation happens, so that will give you confirmation this ovulation has happened, and that's very useful for people with PCOS. And we have a clinically approved accuracy. We have been comparing with lab equipment, and we showed very identical performance. And we have helped more than 30,000 people to conceive with Mira. We have many users globally, and we have there's success story page on the Mira website on this slide, and many of them have really encouraging story. And also, I highly suggest you to take a look at our Mira Fertility Club. It's not only about how to use Mira. There's a lot of really good, nice and touching stories about how people are trying to conceive and how their journey look like. And they also share their information with each other. So it's a very supportive group. So I'll give to Shelley to talk a little bit more about Famlee.
Hi there. Well, again, I just wanted to thank Dr. DiPasquale for all the information that she was able to share with everyone listening in today. Don't want to spend too much time about me because I can see there's all sorts of questions being asked, and I want to make sure we can get to as many of them as possible. But I basically would encourage everyone here to check out the website famlee.com. We do offer free 15-minute visits with one of our providers, so you can at least discuss if the family fertility program is a good fit for you. So I would certainly visit our website to schedule one of those appointments. But essentially what we do at Famlee is we offer fertility, telehealth, and treatment. So for people who choose to work with Famlee, we have a 3-appointment fertility telehealth model. We combine the answers that someone provides to us related to their medical history with the results from the at-home labs, with the clinical treatment protocols for the doctors to really provide a personalized treatment plan that's unique to you. So those treatment plans can involve prescription medications, or they can involve prescription medications and or supplements, or just, kind of a combination to be able to help support you. So again, I would definitely please encourage anyone to visit famlee.com. If you visit famlee.com/Mira and you offer the type in the code Mira150, it will also give you $150 off the Famlee Fertility Program. The way things are built is it's about a 6-month program between the time it takes to take your labs as well as then the telehealth treatment visits. But just thought I would answer that because I can see that question comes through the chat pretty frequently. But again, I would please encourage you to visit our website to learn more.
Thank you so much, Shelley. So next section gonna be our Q&A. So I have seen many very interesting questions in the chat. So let me share that. Okay. So I've seen some questions about Mira, so I'll address those quickly, and then we can go to some questions for Shelley and Fariha. So the one question about Mira is like how Mira gonna work for PCOS. So as we mentioned that Mira you can see your hormone pattern with Mira. So usually with PCOS, you have elevated LH level, so your baseline is really high, and your body trying to ovulate multiple times per cycle, given those follicles are not mature enough, like a small follicle, but your body just trying. So during that situation, it's pretty difficult for an OPK to understand which one is the true ovulation, because you will have to say, those tiny changes in your hormone level, you have to be able to eliminate your baseline level is pretty high, and also you want to say your PDG in order to confirm the ovulation has already happened. And the Mira is able to do all that for you. So hopefully that answers your question about how Mira can be used with the PCOS. And another question about Mira is someone saying that after postpartum, and how long should we wait start to track and how long wait after the delivery. So usually your ovulation could come back as soon as like even 4 months after postpartum, and sometimes it can be a little bit longer. Like some people take 6 months. It's difficult. It's difficult to predict. But if you wanted to be on the safer side, and you can start to test as early as possible, maybe just few weeks after your 4 weeks after like a postpartum, and in order to detect ovulation. Your ovulation will come back before the period. So especially if you don't want to get pregnant, you want to track your cycle, and that's a very nice time to do it. And another question I saw is about FSH, when that gonna be launched, or FSH1. So yes, the answer is like it will be launched this year, and you can use that together with all the other hormone. So you have a complete hormone panel for what you need. Okay, great. And the other question about Mira, we can, if you have specific needs and specific question, feel free to contact our customer support, which is support@miracare.com. And I want to leave some time for the other questions about the hormone or about the health as well. So I guess this is a very nice question for Dr. Fariha. So Sarah is asking, how much vitamin D supplement should we take?
How much what? I'm sorry?
How much vitamin D supplement should we take?
So I think that depends on what your vitamin D level is. So I mean, we do recommend checking your vitamin D level and see what would, what can optimize you. I mean, I often will check people, and they're like going to be in the teens, or like in like 8 or something. I mean, really, really low levels, and you'd be really surprised. And so for those people, then we give them an acute like dose to build it up, and we give them like basically 50,000 units per week. And then after that, recheck to see where they're at and really kind of reach the optimal level. So the amount you take is hard for one person, for me to say, but our goal is to really kind of get that level to be near or above 50 if possible on your vitamin D testing.
Mm-hmm.
And some people could get that by a maintenance of 2,000. Some people need a maintenance of about 5,000.
Mm-hmm.
And the general range I find is between those two.
Sounds good. And also another interesting question, someone is having repeated miscarriage and all the hormone tests are normal, and the polyps has been removed, but it's just another miscarriage again and again. So what's the advice for her?
So the most important thing in that person is really to look to see if there is an autoimmunity aspect going on. So hormonal health is still important. So hormonal health in there is really the vitamin D level, the thyroid, like we talked about, the insulin level, all of that will be important. But usually for like repeated losses and stuff, there is a little bit additional focus on, is there any type of autoimmunity going on that would be possibly almost like rejecting that fetus. And then the other thing is the progesterone level obviously is very important too. So some people, they get pregnant, their progesterone level never maintains a pregnancy. So this is that is a place where actually often, if everything looks fine, the pregnancy is implanting, and especially if you've gotten a couple of times when the chromosomes were normal and you still had a miscarriage, then often people will support progesterone to really give that lining a little bit additional support.
Sounds good. And another question about the hormone. So two questions here actually. One is what is the minimum amount of LH required to trigger ovulation? Another one is for progesterone, what is considered as a low progesterone?
So the LH, I cannot tell you. I mean, by the time when you're getting to that LH component, you're really talking with fertility and having like trigger chats and stuff. And again, your baseline makes a big difference. So there is not an absolute level. It just has to be where there has to be a perception great spike. But where that spike is going to vary depending on what your baseline is. So if you're very, very flat and you spike a little bit, your body will still perceive that, as opposed to something with PCOS where they actually may have elevated baseline LH, but they have to spike enough above that baseline for your body, for your brain to, from your ovaries to trigger that. So there's not a set amount, but there has to be a distinct spike. And then the other thing was progesterone. So progesterone is the level is a little bit the level is a little also hard to do. This is where I was talking about individualization to the patient.
Right.
So you suspect that somebody has a luteal phase deficiency when they have usually a luteal phase less than 11 days, and when their peak progesterone tends to be less than 5. And stuff. So usually with that person, you're really looking when they get pregnant, what is your progesterone level? And if they've had recurrent losses and stuff, I will support it at an early level. If they haven't had any recurrent losses and stuff like that, then we want to take a look. And so ideally, we want the progesterone when you're pregnant to be like 15 and above and stuff. And when you're reaching close to like 10 to 15, a lot of times you're in a borderline range where you need some support. And when you're like 5 and under and stuff like that, that either that pregnancy is not good and is not supplying the progesterone, or your baseline level is very low and your corpus luteum never develops and supplies that.
Thank you so much. And the one question for Shelley, how long does the family plan last?
Most people who work with family end up at about a 6-month model by the time you have time your labs against your menstrual cycle, and then have the telehealth appointments with our provider.
Great. Thank you so much, guys. So I know we still have a lot of questions, but we're running out of time. I want to share some offers with you guys. So one is with Mira. So for people who have stayed until this moment for this webinar, you can have this code explained. So no more unexplained infertility. This is explained, and you can get 10% off on any Mira product on the Mira website. And the date is right there, down there at the corner at the bottom of this slide. And this includes anything. So if you're already a Mira user, you can get some test ones stack up. And you guys know we also offer other fertility related products or health related products, such as fertility tea and some other, period cup and things like that. So everything will be applied to here. And also we have a great code with the family as well. So now you can also get $150 off with the family kit with this code, which is a Mira 150. Great. So thank you guys so much. So before we go, I'd like to do the last poll as usual. So you guys can see that on the screen right now. We like to know how we did, and if this is something you like to hear, and if something you want to recommend to your friends. So this is really important to us. We take it very seriously. So please help us to answer those questions, and so we know how we did. And also at the same time, I'm sharing these slides right now. So you should see that also on the screen under the handout section. I know someone was saying there's a chart that was really small, and then now you have the handout and you can see all the information by yourself. So I'm just giving last 30 seconds for this post to be done. And I really want to appreciate everyone here, appreciate our audience. You take time out from your busy day to listen to this. I hope this has been, helpful to you. Take some time to take care of yourself and manage your own health. That's really, really good thing for you. And for those questions we couldn't answer today, I really apologize, but you can always contact our support for Mira related questions. And Shelley, do you want to share any information about where people can find you if they have a question about families they're interested in you guys, and where can they get those questions answered?
Yeah, absolutely. Thank you for asking. Again, I would just encourage everyone to visit famlee.com. We have a lot of information on our resources tab. We have the free appointments that someone's able to meet with someone on our team to discuss your history and if family is a good fit for you. Again, checking out famlee/Mira offers an additional information. Use the code Mira150 to give you $150 off. And again, I've seen a lot of questions in the chat. How is Famlee different than other at-home labs? Labs are just one of our tools. Here at Famlee, we're here to treat you, which is why we built in the telehealth treatment appointments into the program. So you're not left doctor Googling yourself to figure out how to treat yourself or how to convince your OBGYN to do what you're looking for them to do from what we discussed today. When you work with Famlee, you're getting all that care and treatment together. And if you already work with Mira, your device data is actually integrated into your telehealth appointments. So the doctors are able to look at your device data and then help make more real-time changes related to your care and treatment. So it definitely is a good complement to work with both Mira and Famlee.
Thank you so much, everyone, and also really appreciate Dr. Fariha for this wonderful presentation. It was really, really helpful. And we wish you guys a good day, good night, and wish to see you next time in your next webinar. Thank you so much. Bye.
All right, take care. Bye-bye.
Thanks, everybody.
Bye.
Good luck.